just past the hour, so let's kick off if that's okay. So a big welcome to everybody who's joined the webinar tonight. We're really excited about the topic tonight. We've got a record number of attendees, so it's obviously a topic that's close to all of our hearts. So it's going to be a really, really great webinar tonight. We've got some fantastic speakers for you all. A couple of housekeeping bits before we kick off, if that's okay. If you wouldn't mind, if you're not on mute, if you wouldn't mind just kind of clicking that microphone button, that would be amazing. There is an opportunity for Q&A. We've got two Q&A sections, so you'll definitely get a chance to ask people whatever's on your mind, which would be great. We've also got a chat box at the bottom, so if you prefer to put your question in the chat box, please do so. And then lastly, the last bit of housekeeping is that we are recording this. We've got quite a few people who would love to watch it after the webinar itself. So if you don't want to be recorded, then please just put your camera off and that would be great. Thank you. Okay, so next slide. Thank you, Lizzie. So tonight, this webinar is brought to you by PWS Stronger Together. Many of you may know, but this is a collaboration between the Foundation for Prader-Willi Research and the PWSA in the UK. And really, when we are talking about clinical trials, we come together because we want to get the message out about clinical trials to the whole community. And we can do that really effectively if we're one PWS Stronger Together. And also it helps us work with the pharmaceutical companies because then they can come and talk to you on webinars like today. So we're doing this as a real collaboration. So I'm hosting it tonight. I'm Helen. I have a son, Thomas, who is 9 years old with PWS. I'm also very privileged to work in clinical trials, and I'm a trustee for the FPWR. We've also got Robin, who's going to be co-hosting with me today and posing all the questions. Robin is a PWS parent as well. He's a doctor and he's also on the Clinical Trials and Medical Advisory Committee at the PWSA. So that's enough about us. Let's crack on with the webinar itself. So if we could go to the next slide, thank you. So we have some lovely speakers today, and we're very excited to have Monsi here from Aardvark Therapeutics. Monsi is the Chief Medical Officer at Aardvark. She's a pediatric endocrinologist, but she works as a pharma executive, but also in clinical trials to really bring treatments to PWS, which are both effective and safe. So thank you, Monsi, for being here today. We've got Dr. Gevers and Dr. Sheikh. Some of you may recognize these two lovely speakers. They're pediatric endocrinologists. Evelyn works at Barts down in London, and Dr. Sheikh is up in Glasgow at the Royal Children's Hospital. So they're going to be here today to talk through what it's actually like when you take part in a clinical trial as well. And we've also got Grace, and Grace is one of the clinical trial nurses down at Barts, and she has kindly agreed to come on and help answer some of the questions that you might have as well. So these are wonderful speakers today. Let's go to the next slide. So really simple agenda. We're going to spend a lot of time talking about Aardvark's trial, what it's about, how you can take part if that's what you would like to do, and also then walking through what happens when you take part in a clinical trial. So I'm now going to hand over to Monsi.
Thank you so much for having me here today. Really appreciate your time. Tien also wanted to be here, but he is so grateful for the opportunity for us to be able to speak to you, to the parents, to the advocates and the caregivers and the community. Aardvark was started, and I'll just go through my slides and kind of tell you, there's our disclaimer as a public company. But Aardvark was started in 2017 by a physician, Dr. Tien Lee, and his goal was to bring groundbreaking therapies to patients who desperately needed it. And one of the reasons why I joined this company, I'm a pediatric endocrinologist, as you heard. These were my patients, and I promised them that I would return to practice only when I got this across the finish line, and I'm going to keep my promise. And so this is why I'm here, is to continue that work and to make sure that I can drastically change the lives of how people treat their disease, and specifically PWS. So the Aardvark is a company, again, as I mentioned, 2017. Over that time, the focus has been really about the developing oral medications that are reducing hunger through natural biology. And we'll get a little bit more into that in terms of the science. ARD-101 is our oral drug that we are testing in hyperphagia in Prader-Willi syndrome, and specifically now in our global phase 3 clinical trial that is enrolling, which is why we're talking today. And so a little bit about the drug itself. So it's an oral drug. It's taken by mouth and it breaks down in your stomach. Essentially, once it breaks down in your stomach, it's able to attach to taste receptors, bitter taste receptors that are kind of lining our entire gut lining. But specifically after the stomach, there are receptors there on these cells, and they help stimulate the release of several gut hormones. That also includes the satiety hormone, the hormone that tells you, hey, I'm full. Um, and along with some other gut hormones to allow the brain to understand that the patient taking it is actually full. It works through a very unique mechanism through the gut brain. So it's a signal from the gut because it breaks down in the gut, it attaches to the gut. It doesn't go in the systemic circulation, minimally in the systemic circulation. Sends a signal up to the brain and says, okay, we need to decrease this hunger you're feeling. And because of this unique mechanism of action, because it is just through the gut to the brain, it's gut restricted, it's gut mediated, which actually allows us to potentially minimize the toxicities that may be developed from drugs that are in your systemic circulation or in your blood. Now, how do we know that we have all of these potential benefits? Well, we did a phase 2 clinical trial that really informed our phase 3. We saw an overall reduction in hyperphagia, anxiety, food-seeking behaviors as well, based on the HQCT9, which is a questionnaire developed for hyperphagia. You may be familiar with that. And in this trial, we had ages 17 and older. And I will talk to you about the trial design a little bit more in the next couple of slides. But our age group for the UK is specifically now 13 and older. Again, you'll see the schematic coming up. One really important part of the phase 2 trial was that it was well tolerated in terms of the safety side. And again, it's a phase 2 trial. These are much smaller trials. I think Dr. Givers and Dr. Sheikh will probably talk to you a little bit more about that. But because Prader-Willi is rare, the population is smaller. But we saw some early signals that were really positive that showed us that, okay, we do need to go to phase 3 and try to get this to more patients. So our phase 3. It's a global trial, and I will show you a map of where we're located, but we're in the UK, in Canada, in the US, in South Korea, and in Australia. And individuals will receive either ARD-101 as the active drug or the placebo for 12 weeks. And then we actually also have an open label extension, which means that after you complete the 12 weeks, everyone who completes the 12 weeks actually goes into the open label extension, which is approximately a year at this time. And everyone in open label extension receives active drug. So one thing I mentioned to you was about hunger versus appetite, and this is very distinct for how we look at the general population when hunger is different than appetite. Hunger is something that's done to avoid pain, a penalty to your system, the absolute need to eat. It's mediated by the local gut hormones, as I already mentioned, CCK, and it's through the gut-brain axis. So it's bypassing most of your systemic circulation versus appetite. Now, appetite is a reward based. It's a desire to eat. It looks good. I want to eat it because this is something I would want to eat, not because I have a pain, but it looks pleasurable. These are mediated by some other hormones that are circulating in the bloodstream, and that's like GLP-1s that you might have heard about in terms of different medications, or your family members may have been on it. PWS, it's less often that that's used, but it can be used specifically for type 2 diabetes. And again, is targeted systemically through the bloodstream. Now, once I've kind of talked about this, I like to use this analogy as well, hunger versus appetite. And so if you are in a room, say we're all locked in a room and we have a table and we have your favorite food. So say your favorite food is pizza, and on the other end you have dog food. This is what would happen over the week. your first instinct would be to finish that pizza because it's appetizing. It's something that, it's a reward, it's a desire to eat it, but that would be done. And then you would be trapped in that room. And eventually, what would happen is that you would reach for that dog food because there's nothing else that you would have in the room. And so eventually, to avoid that pain of not having those calories or not feeling full, you would eat the dog food. And that's how I describe this as the pain. And hunger is not because you're not, it doesn't, it's not about what you like to eat. It's about what you absolutely need to have at all times to satiate that feeling that you're having to avoid that pain. And I think once you see it that way, you can really fully appreciate the different pathways. So let's talk about CCK as I brought that up. One of the gut hormones that aardvark's ARD101 allows to release through the gut-brain signaling in the gut. So CCK has been found, and this is through work over several decades at this point. Dr. Tony Holland also had some great papers that he had out from the UK about this, but PWS patients have found to have abnormalities in this regulation of this hunger blocking hormone that may drive the hyperphagia. But it's not just hyperphagia that it drives, it actually also drives increases anxiety, it increases the constipation, it increases fat and body composition in the body, it increases inflammation. And what we're trying to do is improve that CCK signaling along with some of the other gut hormones to really, really push the body to say, okay, you are full. Let's stop that hunger. It doesn't mean that things will get less appetizing. It's just that that absolute need to eat, to fill that hunger, that void is going to decrease. So I mentioned ARD101 in our phase 2 clinical trial. So let's talk about it a little bit more. So ARD101 was tested in PWS patients. As I mentioned, it was 17 years and older in this population, and it was only a 28-day study, open label design. Hunger was measured through an HQ-CT, as you see here. And on the right side, what's important to see is that there was an average reduction of around 8 points in the HQ-CT score, and that HQ-CT goes to 36. HQ-CT 9 is 9 questions with 36 possible points. And to see that decrease in hyperphagia and overall in different domains of this, so in terms of behavior, in terms of drive, in terms of severity, we saw an overall decrease. And I think that was a very important signal to see while we still saw a potentially clean safety profile. And so those two things are very important in clinical trials. Not only is it working, or you're seeing early signals that it's working, but you're also seeing early signals that it is deemed to be tolerated well by the patients taking it. Those both are, in my mind, should be equally weighed in because you want it to work, but you also want it to be safe. We also saw early signs of improved fat and muscle balance. So what does that mean? That we saw a decrease in body fat while maintaining or improving lean fat or lean muscle. And that's really important in the population because, as you know, in PWS, you have less muscle mass with hypotonia and a more potential to decrease lean mass. And so seeing this is really important with any trial. And then in terms of the safety profile, it's been well tolerated across multiple clinical trials at this time. So we've dosed well over 70 patients with this drug. Majority of the side effects have been mild and resolved. There have been no known other interactions with PWS medications. And that's important because if your family members or loved ones are on other medications, you want to make sure there's no other interaction. And that's where we've had no problems with other medications that patients are on. We've also had no expected risk to liver or kidney or risk to the immune system. And the only reason we highlight that is, again, because it's gut mediated and gut restricted, which means that it's not absorbed minimally absorbed in the systemic circulation. Again, important things to have so you know that it's not going to the liver or the kidneys or affecting anything to do with your immune system. So all of that being said, this is why we're in our phase 3 trial design. Right now, this is the design for Canada, the UK, and South Korea. The reason it's pointed out this way is because of the age. So specifically in the UK, we're going 13 years and older. That was always our primary protocol. However, we do absolutely plan on going in a younger population. It's just that currently, as sites get initiated and are able to have patients come to their sites, we're going to have 13 and older, but we are in the process of figuring out when we can have a younger population in the study. It's a two-arm design, and as I mentioned, 45 will get ARD 101 and 45 will get placebo. It's a randomized, so that means that you're randomized either to one of these two arms. You do not know which arm you're in. And then it's 12 weeks long, and following that, you have a 1 year long open label extension period, which you'll see the design in just a minute. We're evaluating hyperphagia using the hyperphagia questionnaire for clinical trials, HQCT9. And I will also mention that here that, and we really have not given too much guidance on enrollment, but I'm happy to share that we are just past the 50% mark of enrollment. But that means that A, there's still moments for people to be in the trial, but also that we have really great momentum for people to participate. And we're really been happy with the advocacy groups and the community coming together to support this trial, but we are grateful for the participation. And we want everyone to get the opportunity in the UK as well. So we do have availability for people to participate. And we're about to get started and clinical trials in the UK. I'm going to show you exactly where we are in just a moment for our locations. But just quickly, the open label trial design, patients, again, who roll over from completing the 12 weeks will get the opportunity to get the active drug for the entire year and hopefully longer. The point of open label really is to not just get the active drug, but also now to look at safety for a longer period of time, as well as continue to follow hyperphagia changes now that everyone is on the active drug. And again, some of the qualifiers here, in which you will see in multiple ways. And I'm going to give you QR codes that'll allow you to kind of look at the inclusion criteria for the trial, but must have a diagnosis of PWS, must be 13 years and older, must have the same caregiver at all the visits, and then also be able to complete the questionnaires. Now, one thing we really wanted to address was that we wanted to make this as easy as possible. It's a clinical trial, so me just saying that easy as possible just seems impossible because of the burden that clinical trials place on families. But I will say that we did everything possible, listen to the community, listen to the advocacy groups, and listen to the PIs who know you so well and wanted to make sure that we took into account the nuances and the burden that you face day to day. And so, in terms of the trial design, we made a simple schedule: 4 clinic visits only, and then 3 telehealth visits that are spread out, which means that you just have a phone call or a Zoom meeting to talk through how the trial is going. It's an inclusive design, which means that you really don't have to fast or skip meals. That was really important to us as well. Now, are there labs? Yes. Could we avoid those? No. But we tried to minimize them as well. What are the most essential things that we're asking? What are the safety labs that we need? And what are the most essential questionnaires even that we need in order to get enough data to support the study? Again, we're asking for a stable routine, and that means that trying to make sure that the caregiver is consistent at each of these visits, because once you're at one visit, you'll kind of know the routine of each visit, and that's important from a routine standpoint for you and your loved one, but also in terms of the questionnaires, it really needs to be filled out by the same person. And then we also wanted to make sure you travel to these sites. It changes your routine for you, your family. We wanted to support as much as we could. So we actually offer now travel and lodging as well. We cover everything. It depends on where you're going, but we cover everything. And we want to make sure that you have that support. One less thing to worry about. And then lastly, next steps is that we wanted to provide an open label study, which is what we have, to make sure that you're not just participating in this small study, but you have the opportunity to get long-term therapy as well. So I told you where we are going to be. This is the global map of where we are. So the US, Canada, UK, South Korea, as well as Australia. And we wanted to keep it as open as possible, but still make sure that enough patients had the opportunity at each of these locations to enroll in the trial. And this is where we are in the UK. And so I have great news that we actually have activated our first site, which is Dr. Greening's site, but every other site here is almost at the cusp of being activated. And then they have a few additional steps they need to take at the site level in order to get patients to come in. But we are extremely grateful for Dr. Zaman, Dr. Gevers, Dr. Sheikh, Dr. Greening for being sites for us and making sure that patients get the opportunity to participate in this trial. Now, I'm going to show you the QR codes. This is on the left side. I'm going to keep this up just for a few extra seconds and I can always come back to it. But on the left side is our main website that is the Hero for PWS. It's our main website that allows you to kind of get more details about the study. And if you're interested, there's a link that will send out to one of the services that we're using and partners that we're using for this trial, which is LeapCure. Leap Cure is a service we've used because it's kind of a what we call a concierge service for families and patients, and it also helps balance the burden that gets on sites as well. With increased interest, there's a lot of logistics and back and forth that happens. We wanted to minimize that. So Leap Cure is a company that works specifically with patients and sites, identifies if you're interested. So if you fill out whatever the link is that you'll get through this QR code, it'll send them a message. They'll connect with you, ask you a few additional questions to see if you're qualified. And that's called pre-screening. This pre-screening is then sent to the site, say, hey, we have this log of patients. They look like they can qualify. What do you think? Do you have availability? And then the sites will say yes. Let's figure out how we can get them in, and then they will identify how and when. They'll arrange travel. They'll arrange your from the time that you speak to LeapCure to the moment that you're at the site for the screening visit. So hopefully it's decreasing your burden. And so far in other countries, it's really helped in terms of decreasing the time turnaround time as well as the burden to you from all these planning all these other stages in order to participate. And then on the right side, we have the clinicaltrials.gov website. Again, this is the website where all clinical trials and very specific information is. The left side is a more friendly read through versus the right side is more kind of a formal version of what we're presenting on our website as well. And then finally, I really want to show you LeapCure here. So LeapCure, again, as I mentioned, it's kind of the concierge service, if you will. So it really helped us expand the trial, connect patients and their families to the sites, and assist with really the participation logistics, as I already mentioned. What you will see is possible digital campaigns. We are working with them. It is not spam. It's a valued partnership for us. And it's helped us really make sure that the trial runs smoothly from the very, very beginning of interest. And so this is actually the Leap Cure QR code. So I'll leave this here for a second and make sure that you have the time to at least grab this. But I think that this recording will also be available, so hopefully you'll be able to get the QR code separately.
Great. Thank you, Monzi. Now I think it's time for questions. Robin, are you on? Um, to see if Robin's.
And Helen, may I just quickly add, I wanted to say thank you. Thank you
Yes, I
to
am.
the
Thank you,
advocates.
Swansea.
And thank you to the families and thank you for participating. I think a protocol is just words on paper and it comes to life because of the community and those that participate. And we couldn't do it without you. And again, Aardvark, myself, we are extremely grateful for your interest, your participation, your advocacy. It's incredibly meaningful to us to get this across the finish line, and we can't wait till the day we do. So thank you again.
Thank you very much, Monzi. That was a couple of questions that came in. Um, can we ask you, you said that there are 4 in-person visits and 3 telehealth visits. Over what period of time are those visits happening? Is it during the 12 weeks or is it in the entire year of the study?
So for the 12 weeks, so it's 4 in-clinic visits, and then 3 telehealth visits that are spread out over 12 weeks. And again, this is probably the lowest we could have gone without losing critical moments of understanding how the drug is working, and in fact, getting the questionnaire. But we had more, and then we heard and listened specifically to the families and the investigators, and we recognized that in 12 weeks, it's a lot to go multiple times and 6 times, 7 times, it's a lot. And so we actually took that out and took out some visits and said, okay, this definitely can be telehealth. You can call. This is a phone call. This is not an in-person visit. So that's how we reached to 4.
That's great. Thank you. Years old. I'd really like my child to participate, but they are 9. When do you expect the age and
Oh, Robin, you've gone on mute. Okay.
in I would really like my child to take part in the study, but they are now. When do you expect the age in the U
Sorry, Robin, I think it keeps going on mute. That's better.
in the US? The age has been lowered to 10 years old. I would really like my child to take part, but they are 9. When do you expect the age to be lowered in the UK?
I hope soon. I will say this, I don't want to overpromise, underdeliver, but we are actively working on lowering that age group. And so as soon as we're able to confidently say that it's been accepted, because it has to go through the regulatory side and acceptance there. So until that happens, we won't give you an exact date, but I'm telling you, we're working actively on that.
Okay. Uh, the trial 90 page and that you've recruited around half already at other sites around the world. How long do you expect recruitment to be open to include the UK?
Uh, Great question. And so we don't have a limit on how many patients can come per site. But because sites are now active, so actually you're right. So I think I saw a comment this pop up that the website doesn't say recruiting yet. So actually that is fresh news as of today that we actually have Dr. Greening's site up. And so that means that more of the rest of the 3 UK sites will be up very, very soon. And then that will change on the website. It always takes a little bit of time. But that being said, I think that within the next 2 to 3 weeks, sites will be ready. And it's just individually based on when they flag that they're open. But then you will have time. You will have time to enroll. I will say that in terms of what we know for the interest, we're doing everything we can to make sure that there's enough time. And I think that we're looking at the next couple of months to really make sure that you have time to come in. But again, why we're having the webinar, why I'm very transparent with you where we are, because I want you to know so you have the opportunity once the sites are open to contact and see when you can get scheduled if that is something you want to pursue.
Okay, here's another question from our pool. As you probably know, the current drug XR is not yet available in the UK. If Aardvark's phase 3 trial goes well, how quickly would you look to get approval for it in the UK?
Again, great question. As soon as we can. And so there's a pathway, there's different pathways that have to be um, accounted for. So, and this is not just aardvark, it just depends on the FDA approvals through the FDA and then how we would pursue ex-US. But I will say this, we would not do a trial in a country where we did not want this to be approved. I think that would be absolutely cruel, and that is not our intention whatsoever. So it is absolutely our goal to have this approved there. It's just that we have to follow the regulatory path that's set out for us in this field.
Okay, thank you. And another question from Linda, files via the website QR code given earlier, or is there another way?
Sorry, I missed the first part of the question, Robin.
Do we try the website QR code, or is
I'm so sorry. I don't know if it's my connection, but I think you're breaking up a little bit, Robin. But I think it was about the QR code. Um,
I think
yeah.
the question was whether there's another way to access the website rather than just the QR code.
Oh, yes, it's Okay, Robin, it's breaking for you too. Okay, great. So maybe if it's me, I apologize. Hero for PWS.com is the website. So hero for PWS.com. But I think that we can have the QR code sent, Helen, maybe through an email communication.
Hi, excuse me. Yeah, sorry, it's my question. It's Linda Jenkinson's question. Sorry. It actually says, do we actually apply for the trials via the website / QR code given earlier?
Yeah,
Or
so if you
is it another way? Do we
great
apply another
question.
way?
So there are multiple ways actually. So
Right.
we wanted to give that as an option too. So as I mentioned, Leap Cure. So if you go to
Ah,
Hero PWS and that QR code, there is a link that will ask you if you're interested, go and it'll point you to the direction of where to go. There's, I think in the bottom right somewhere, it's a link that says if you're interested to participate, and then it'll ask you some early questions, just like a couple, just to identify if you are the person that you are filling this out for qualifies. And then once it's a pre-screen, so very short couple of questions, and it'll send you your information then to Leap Cure, and then Leap Cure will contact you. A
ah,
project manager from their team will contact you to ask more questions and then get you to the site. Similarly, if you were to go to the clinical trials website, there's the contact person's information,
right.
and then you can connect through that as well from clinicaltrials.gov. But I know Dr. Gevers and Dr. Sheikh are going to be speaking as well on how to participate. So maybe they have their own site practice that they can tell you on how to connect with them as well, which probably is similar across the board.
Thank
And,
you very much. Thank you.
and Linda and everybody, we have put the link as
Okay, and
well to
maybe the
Leap
last question
Cure
we've got here.
Okay. Yeah.
in the
Thank you.
chat.
Thanks. Thank you.
Okay. Suk Gill has asked, other trials have ended prematurely. Do you think there is a risk that this could happen here in the UK as well if there aren't enough indications that the drug is performing as expected?
Great question. And it's true, right? We don't know what we don't know. This is why we do phase 3 trials, because we want to understand. What we work off of is the potential seen in other trials. So in our phase 2 trial and what we've seen there, which is a lot of potential. But you're right, we don't know anything until we actually do a larger clinical trial that's a randomized placebo controlled. Those are really important in order to truly establish effect, because also what you don't want is a drug out there that has minimal effect but somehow got approved, and it doesn't really change your life. It doesn't change how you understand the disease or how you manage the disease. And I think that it's necessary to do these, and we never know what it's going to end up like, but we have a lot of faith in the mechanism of action. We have a lot of faith in the phase 2 trial, and we are really hopeful. And hope is not a solution, but is a path.
I think we've got time for just one more question, then we're going to have to move on to Dr. Gevers and Sheikh, but we will get back to everybody with the answers to their questions afterwards as well if we don't have time.
Thank you so much. Great questions.
Okay. And just to reiterate a point, what will happen after the 12 months and successful?
Great. For the OLE. Okay, so open label extension is for 1 year. And as a company, our goal is to offer that until we get approved, essentially. But right now, as a small biotech, we can offer 1 year, and then the goal is to continue it. But that is the path.
Great, thanks, Monsi. And apologies for the audio going in and out for quite a few people. It's quite difficult sometimes. So that's brilliant. I think that was a fantastic section. Thank you for all of the questions. They were amazing. And Monsi, thank you again for being on with us today. If it's okay, we will kind of move on to Dr. Gevers and Dr. Sheikh, who are going to walk us through what actually happens during a clinical trial visit. Dr. Gevers, over to you first, I think.
Thank you very much. So welcome everybody to the webinar, of course. It's the information that we have received already is great. Many parents and young people with Prader-Willi syndrome want to know how it actually practically works if you start a trial. So I'm going to show about 5 slides, not very many slides, to lead you through what will be happening. And then we've got some time for questions I've got here on the call also our research nurse, Grace Wild, and she's been involved in previous studies for Prader-Willi syndrome at our site as well. And I and Grace work at Barts Health NHS Trust Royal London Hospitals. That's in East London. Next slide, please. So I'm going to talk a little bit about what happens before the visit, what then happens when you come for the first time at the screening visit, what happens afterwards, and what happens at the baseline visit. Next slide. So before planning the screening visit, lots is happening already. So most of the time people contact us and contact the research facility either because they've seen on the official website that we are a site, or they've gone to the Prader-Willi Syndrome Association or FPWR and seen at which clinics the trial runs, and our information is there. So most of our patients come in that way, or of course from our own clinics or clinics in London that know us, and the consultants will know whether we are open and whether we accept patients. So then we sent out patient information leaflets to the parents to tell them what exactly the trial entails. We offer them a telephone appointment to discuss things in more detail, and then we answer their questions. And if they are interested in participating, we then ask whether they would be happy and give us consent to ask for the clinic letters from their clinic, because we have found that if we see families at that screening visit without knowing the young person with Prader-Willi syndrome, then you get a lot and you need to try and get a lot of information in a short amount of time to assess whether all the criteria are met and whether there aren't any reasons why somebody cannot take part. So we have found that it's much easier if we ask for the clinic letters beforehand, we screen them all, we get to know the young person a little, and if we think that there are reasons that the person cannot attend, then we can try and clear those up before we actually see the patient. There are people that will not be able to take part because they either don't fulfill the inclusion criteria, or sometimes there are reasons that are in the exclusion criteria. The list of exclusion criteria is very long, so it is difficult to communicate that in a leaflet, but that will really be assessed before that first screening visit or at the first screening visit. So what are the most important inclusion criteria for the aardvark study? And Mansi has mentioned most of them already. So of course, Prader-Willi syndrome, that needs to be genetically confirmed. So we need to have the result of the genetic test. So we also ask for that before we actually see you. You need to be 13 years and over at the moment. You need to have so hyperphagia. You need to be on stable medication over the last 3 months. And that doesn't mean that it can't have changed at all, but it shouldn't have changed by large amounts, and that's a little bit different for each different drug. But that is exactly what we can get from letters that we offered. And then another inclusion criteria is that the young person needs to have the same caregiver for at least 6 months, who needs to look after the person for 4 waking hours per day. So most of the time when somebody lives with their parents or one parent at home, that is not an issue. If somebody is in accommodation, so a boarding school or a Prader-Willi house, then that sometimes can be more difficult. But so we deal mostly with young people of 18 years and lower, and most of the time with the boarding schools, that's not a problem. And we can identify who is willing to come to the clinic appointments and be the same and have the same caregiver. And I think this question came up already. How long do you need to be out of a previous trial? And that is 30 days. But you need to be off if you were taking part in the DCR from Soleno and you are on DCCR still you need to be off DCCR for 2 months because that drug acts for a longer time. That's a relatively short period. For many other trials, you need to be out of another trial for 3 months, but here it's only 30 days. Then some of the exclusion criteria. So these are the most important ones. A significant infection in the last 14 days. So that doesn't mean that you can't take part at all. You just need to delay, and we wouldn't want you to come to the screening visit. Difficulty swallowing tablets is a problem because you need to swallow 2 tablets for 2 different meals. So you need to be able to do that. We can help, and your own consultant probably can also help to teach how to swallow. There are some quite good instructions how you can teach young people, including people with learning disabilities, how to swallow. And with our previous trial, we actually haven't had a problem with that. If you have type 2 diabetes, the diabetes needs to be controlled on tablets or on insulin, needs to be stable for at least the last 3 months, and your glucose levels need to be in a reasonable good range. So we measure that with something called an HbA1c, and if your HbA1c is more than 8.5%, you don't take part. High blood pressure is also a reason not to be allowed to take part, but it needs to be quite high, and also it needs to be uncontrolled on medication. So that's not that often the case that it's uncontrolled on medication. You can't have had surgery in the last major surgery in the last 6 months. You can't have a significant mental health disorder that is uncontrolled, so you can be on medication for mental health conditions, but it needs to be stable. That can be quite grey. If we can't decide whether we think it's stable, we would discuss it with the medical monitor and then make a decision together whether we think somebody can take part or not. A severe liver condition is a problem. Now, when you weigh more than ideal, you can get liver abnormalities, and most of the time they're not so severe that you wouldn't be able to take part in the trial. And then you be on medication that affects weight or appetite, which is understandable. Next slide. So then at the screening visit, we would go through the consent form. So that are the forms where you say that you allow to agree and you want your child to agree. And we would also ask the young person with specific forms whether they are happy to take part. We would always be very apprehensive if the young person really doesn't want to take part. Then we really feel that we shouldn't do the trial, but sometimes they change their mind or they haven't understood it. But in general, we would like them to agree. And most of the time that's the case. If the parents want somebody to take part, then usually the young person also wants to take part. The caregiver also needs to give consent. So that takes quite some time because it's a very official legal process. So you need to go through each single sentence on that form, and you need to initialize it. And then we need to go through detailed medical history where almost everything in terms of previous illnesses, medications, surgery, needs to be without. So again, that is where it helps that we've asked for letters previously, so that process is a little bit quicker than it otherwise would be. Current medical problems are important, ongoing investigations, and also current medication. So we always advise to take current medication with you, so we know exactly what's in. And we also, of course, want to know the social environment. Who are you living with? Do you go to where do you go to school? Who's your consultant, etc. And then you need a detailed current assessment of all the medication, of how hungry the person is when that developed, but also how you manage it at the moment. and how Prader-Willi syndrome at the moment is affecting the young person. What are the features that are really difficult? What are the things that are easier, etc. What other conditions does the young person have, and how well or unwell is the young person involved? And then we need to examine the young person, and then there are also the questionnaires that need to be filled out. So that are the questionnaires being filled out by the caregiver, and also by the clinician, so the investigator for the trial. Next slide. And then what do we actually need to do for other assessments? So weight and height, the usual things that most people would also get at a visit to their consultant. So weight, height, blood pressure, heart rate, respiratory rate, temperature, an ECG, and then blood tests, and a urine test for girls if they are but yeah, over the age of 13. And that needs to be done at every visit. For most of the time. There are some reasons why it doesn't necessarily need to be done every time, and that's very standard for all trials. Next slide. Then after the screening visit, the results need to be assessed. So the questionnaires are assessed, the results of the blood test and the ECG and the other investigations are assessed. If there are things that are unclear or do not fulfill the criteria, then we may need to get further information. And then we may need to talk to assess ourselves first. Are those abnormalities clinically significant, or do we feel that they aren't significant? Sometimes you get, for example, an iron level that's just below the normal range, and we could say that's not significant, or maybe something that isn't measured, that we think is an accurate measurement. So we first need to assess whether it's clinically significant, and then we need to assess whether there is anything that means that there's an exclusion criteria and a young person cannot take part. And if that's the case, then sometimes it's very clear and you can't take part. Then if it's a blood test, then we can redo the blood test. So the second time, the results are such that you can take part. But sometimes there are things that can't be solved. For example, liver function, indeed, that is very much out of the normal range, and that doesn't normalize. Or a blood pressure, indeed, that is very high and suddenly doesn't respond to treatment anymore. So there are unfortunately reasons why sometimes unexpectedly people are not able to take part. Next slide. So then, if the decision has been made that there is the opportunity to take part, then you go to the baseline visit. The amount of time between the screening visit and the baseline visit is at the most 4 weeks, but can be shorter. And the baseline visit is the really important visit, because that's the visit that everything gets compared to. So we need to get lots of details again, and we need to get everything very accurate again. So again, a weight and a height, etc. And we need to know about any events since the screening visit, updates on the medical history, updates on investigations that potentially could have happened, change in medication. We need to examine again. We need to do the blood test and the ECG again, unless the time between the screening visit and the baseline visit less than 7 days. But that is difficult because sometimes the results will not be back before 7 days. So most of the time you do need to take blood tests again. And then there's a small possibility that those blood tests are outside the normal range, that you would still not be able to take part, but fortunately that's that's common. And then you need to fill in the questionnaires again, because that are the questionnaires that everything is going to be compared to. So then we, if everything is fine, there's a decision to proceed. Of course, at that time, we don't know the blood test results yet. And then at that visit, you are assigned to either the dummy drug or the real drug. And the research pharmacy is involved in that. So we as the doctors don't know, the research personnel doesn't know, and you as the family don't know. So nobody knows, which is good. Then we actually get the medication from the pharmacy, and then the first dose of that needs to be taken in clinic to ensure it goes well, that the person is able to swallow the medication, also that there's not an immediate reaction, and also at that time blood tests are being taken to assess how quickly does the drug get cleared from your body again, and that is very common in this, that we need to learn more about how quickly medication is cleared from the system, and very often that's different in adults compared to children, and children of different ages. So therefore that needs to be done. And that's a blood test beforehand and a blood test 60 to 120 minutes afterwards. And that's at the 3 times that you come for the visits. So the baseline visit, the second face-to-face visit, and the last face-to-face visit. But in general, indeed, like Monsi said, the number of blood tests is relatively low for this type. I'm really pleased that has been that the company has been able to do that. Next slide. Yeah, I think that was it. So yeah, any questions we are happy to answer, and Grace as well, and I'm sure Dr. Sheikh as well.
That's great. Thank you very much, Evelyn. And this is kind of a general question, I think, from our audience. What is the upper age limit for participation and recruitment in the trial?
Yeah. So I think that there's no upper age limit to take part in the trial, but there are research sites for children and for adults in most hospitals. In some hospitals, they are combined. In our hospital, it is separate. Our clinical research facility for the children takes part in the trial, but not the clinical research facility for adults. So we are allowed to take people,
Okay.
including, and if they turn 19 during the trial, including the open label extension, we are able to continue to have them in our clinical research facility. But I think that, for example, for for Glasgow, Dr. Sheikh, that's slightly different already.
Yeah, no, I think thanks, Evelyn. Thanks everybody. So in Glasgow, it's similar to yourself, Evelyn, that we're kind of pediatric CRF, so we can take them up to 17. I mean, obviously, if they're in the trial and started the trial, as we will continue within that. So even if they become over 18, we will usually continue to keep them in the trial. So, but we can't start somebody who's already above 18. I think that was a question that one of the had in the chat. So unfortunately, sadly, we won't be able to take anybody above that age in it, but we could keep them in if they've already started and participated in the trial for a little bit longer. Do we want to try and go through the questions? Robin, you're going to go through the questions, and
I think I saw another question, how big tablets are, and I think Grace is able to answer that.
Apply to.
Sorry, Robin, I couldn't hear you.
Yeah, I think if Grace, if you could answer about how big the tablet is, that'd be amazing, because I think that's a question from somebody as well.
Hi, sorry, I had some with my laptop just freezing then. Yes, the tablet size is 10.5 millimeters diameter by 4.5 millimeters. So really quite small, like a small kind of paracetamol tablet.
Did you hear that, Helen? Although it's 12 millimeter by 5 millimeter.
Fantastic. Thank you. Sorry, can everybody hear me still? I think everybody's having problems with the audio tonight.
I think I can hear you, Helen. I think there's just some people with. I think most people. I think there is a problem with some of the internet connections.
Do apologize about that. I think we have some more questions if that's okay. I can't see Robin now. So, can you tell us how long visits actually take? Are that certain visits longer than other visits?
I can answer that. I suppose it really depends on what we're doing in terms of blood tests and questionnaires. If very, I mean, again, usually what happens is kind of the questionnaires, if electronically, Wi-Fi codes and so on, so they can take a time. So I would probably plan for you're going to be there for most of the morning.
Yeah, exactly. I would say the screening visit is a very long visit. The baseline visit is also a relatively long visit. So indeed, you're looking at 2, 3 hours. And then of course it also depends on how easy it is to do the blood test. And then the third visit, maybe a little bit quicker, the third face-to-face visit, and then the last visit is quite long again as well, because that is what the final data are that are being compared to the initial visit.
I would
Okay.
probably plan that you're going to be there for most of the morning, and so yeah, I would probably
Yeah.
say that you can be there for the most of the morning because sometimes the logistics and practicalities of just even the ECG machine, as we've all come across, that they don't stick or don't work, and so there's also that. But yeah, I would normally say that you're going to be there for most of the morning.
Thank you. And also, could you just clarify what the age limit is, what the ages are at the different sites? We've had a couple of questions in, what about the Cambridge and Leicester site? Because
So from Glasgow, it's going to be 13 and above, up to up to 18 or 17. I assume that's the same for Evelyn. I'll let Evelyn see, but and
Yeah, so
probably
we can take up to 18. And maybe Monsi knows about Leicester and Cambridge. I don't, by heart.
Yes, I'm on mute. Sorry. Again, we have Dr. Zaman has the ability to take adults as well.
Yeah.
and I'm assuming Dr. Green is a pediatric endocrinologist.
Yeah.
So again,
Probably not.
I'm probably just assuming that it's probably going to be children as well.
Perfect. Perfect. Thank you. So we have some other questions. What happens with our regular visits? Do we need to speak with our local endo or liaise with them before the trial?
So usually we would have liaised already because we have asked for the letters. Also, when you do take part in the trial, a letter goes out to the GP to inform the GP, and also goes on the clinic letters. And yes, you still would go to your normal appointment with your own consultant because they will still be looking after all other aspects of Prader-Willi syndrome. But we will, they can always contact us, and they will get information that your son or daughter is taking part in the trial. And you will also get some information yourself that you are able to show to anybody who you think it's important for that this young person is in a clinical trial.
Brilliant. Thank you. And along those kind of lines as well, there's been a question that's come in before. Is there someone to speak to in between visits if we have any worries?
So usually the kind of clinical research staff or the nurses staff or the kind of team will always be able to be available and contactable. So so there will be a team in Glasgow, there'll be team in Barts, and so there will be always somebody contactable that you can discuss the trials and so on if there's any queries that they have or any concerns they have during in between visits.
That's amazing. Thank you. It helps put people's minds at rest, I think. And also on that kind of vein as well, how are we being monitored if my child goes into the open label extension?
So, well, I have to look at the kind of, so I think there'll still be kind of regular visits and so on as part of safety and long-term follow-ups. I can't remember off the top of my head exactly. Maybe I don't know if Monty knows.
They're actually further spread out in the open label, so less visits because it's a year long, and so we actually made that even less over the year. And again, there's ways to also minimize the visits where you're last visits in the 12-week trial is your first visit for the open label trial. So you can combine those as well, which we recommend only because then you don't have to do double the assessments. But again, it's much more spread out through that OLE.
Thank you. I think we've just got a couple more questions, if that's okay, because I know we're nearly up on time, but we're really keen just to get through the questions because I know everybody's so interested in the trial. There's a question here. Is there an option for like visual picture cards or some different communication methods to be given to support the child if needed? So I don't know who would like to
I
take a
think
stab.
Grace was going to, Grace
Great.
will be
Great. Answer that
answered.
with
I don't know whether
she's
sorry.
I think she's gone on mute.
Grace is on mute. I don't know where the audio is going again. Sorry, Grace.
Hi, sorry. Yes, sorry, I think it's my internet. Sorry, I didn't hear that last bit. If I keep my video off, I might have it. I think it'll be better.
Give it a whirl. Okay, so is there an option for visual picture cards or some different communication methods to be given to support the child if needed?
Yes, so absolutely. So this is kind of more covering general communication rather than study-specific things. But yes, we have learning disabilities nursing team at the hospital who provide lots of different resources, picture boards, including kind of general walls and all medical. We kind of work with the family and the caregivers to work out what communities work best with the child.
Fantastic. Thanks, Grace. I think one of the last questions we've got is there an opportunity to use our local service for bloods, or do we always need to go to the clinical site?
So
You need to come to the clinical site because unfortunately we're going to be doing all the other assessments and so on as well, and it also needs to be centralized. So unfortunately, yeah, it would have to be the clinical site.
Fantastic. Thank you. Does anyone on the call have any further questions they want to either come off mute and ask or pop them in the chat? I think we've tried to answer them, but if we haven't, please raise your hand and we'll get to them quickly before we finish. Any more? Just being aware that we'd love to. Oh, got one more new one coming. Oh, yes. What have the side effects been? So, is there any information on that you can share with us, Monsi?
Yeah, absolutely. So I can speak to phase 2 because phase through safety data we're collecting. But phase 2 specifically, we phase 2 was in 2 parts. So we had a lower dose section, and then we had a second part that was the higher dose up to 800 milligrams, which is what we're dosing in our clinical trial, and for phase 3. And so it's more relevant for the second half. I will say, so how generally safety events are graded are grade 1, 2, 3, mild, moderate, medium. I mean, it's like, it just depends on how you verbalize it, but most of our lower dose were mild and self-limiting. And did not require really any intervention, which is an important piece because once you have to do an intervention or you have to seek care, it changes how severe it's graded as. And so for the second part where we had the dose that we have in our phase 3, some of the side effects, which we're following in the trial actually, and it wasn't side effect, it was a one-time event that happened, diarrhea, and which was self-limiting, resolved very quickly, but then it's something I mentioned about CCK, one of its mechanism of action is to increase gut motility, which we actually think it could be a benefit. But it was just noted in phase 2. So we're following gut transition by a really simple stool questionnaire to understand if we are increasing motility, because given the population with as much constipation there is, this could be a benefit. But again, we're following it in the phase 3. So that was one of them. The other was bitter taste in the back, secondary to reflux. I want to make that very clear. It was secondary to reflux as it was noted. And again, it happened once and it resolved. And all of these participants actually completed the trial as well. So nothing has limited them. But nothing that has been consistently noted in our trials, I will say. And it's a gut restricted, gut mediated. So again, speaking to the safety profile, but it is gut mediated. So to have some gut issues is not uncommon, but it's been very self-limiting and actually hasn't been much at all, based on our phase 2. We'll see what we see in their phase 3.
Fantastic. Thank you. Everybody's really getting engaged now, so I've got another couple of questions. So sorry to keep everybody. This is really important though to get through them. So a question said, I've signed up for the trial and had 2 conversations with Leap Cure and asked about blood tests as the first question. They continue to enroll my child and get my consent, etc. I'm confused about why they pursued it when my son will not tolerate blood tests.
I'm not sure we can answer that. I don't know why Leap
Yeah.
said that, because obviously blood tests are an important part of the clinical trial. So I'm not sure, and apologies for who that's affected. So I think that's probably to clarify that Leap Cure.
Yeah, I'll get in touch with them and see kind of the situation because again, this feedback is very important to us, and we can't improve practices or at least understand what happened without the feedback. So appreciate you noting that, and I will talk to the team and see what happened there and make sure we have an answer.
Fantastic. And do we have a timescale on when we will know if the trial is successful or not?
So so as a public company, it's interesting, and then you've probably seen private companies, public companies, but as public companies, we have timelines that we have to share externally. We always want to go faster, but in terms of when data will be out in the public, and we talk in quarters, which I apologize because I never talked in quarters when I was practicing. But the third quarter of this year is when. So third quarter is from July to September. And so somewhere in that time frame, we're planning to have data. So we have to finish the trial before then and clean the data and process it by that time frame.
Amazing. That's really helpful to have those timescales on. Last 2 quick things, and then we will finish because what is the age limit at the Royal London? Is a question from Sarah.
Yeah, so we can include anybody who's 18, and if they turn 19 during the trial, or even 20 if they're in the open label extension, that's fine. So we won't stop people being involved, but we can't take on anybody who is 19 years or older.
Okay. And then very last, our daughter is 37 and it sounds like she'll be unable to take part in the trial. If this gets approved, would it be something that would still help her?
So I will say this, I would work with Leap Cure. There is one site, right, that is taking adults. So we do help with travel and lodging to the sites that will accept adults. Work with the site, work with Leap Cure. I don't want to inundate the site with all the patients coming with a certain age group, but we want to make that as flexible as possible. So if you are interested, connect with Leap Cure or the site, let them know you're interested once they're ready to accept patients. But we will support the travel and lodging if you want to participate at that other site.
Perfect. Thank you. And I think that wraps up our session. We've had so many questions, which has been fantastic. So thank you to everybody for all of those. Just really to finish off by saying thank you to all of our speakers today, to Munzi, to Dr. Beavers, Dr. Sheikh, to Grace, to Robin, and for everybody in the community for taking part today and taking time out your really busy evenings as well to attend the webinar. So please reach out to us if you have any further questions. I think we had a last slide, Lizzie, that just had our PWS Stronger Together website on. So if you want to keep up to date with Aardvark's trial, we will have updates on there and news up there regularly. So please just take a note of the details on this slide. So there we've got the PWS Stronger Together website. You can follow us on LinkedIn and Facebook and so on. We've also put 2 QR codes on the bottom if you wanted to connect with us either at the FPWR or the PWSA. Please just zap those as well and you can get updates there. But I think that's it from us tonight. So we'll just end it again on a big thank you to you all.